I welcome all the candidates who have cleared the screening stage of pediatrics quiz held by DocTutorials. And we have selected total of 6 candidates who are in the final year or internship and who have done exceedingly well in their screening test. So this is going to be a mains test. The mains test will comprise of 6 rounds, and the questions are a combination of one-liners, clinical scenarios, and you know the answer, perfect. You don't know the answer, I will be talking about relevant takeaways from that particular thing. And the video will be beneficial for those who are taking the quiz as well as those who shall be listening to the quiz later on. So let us begin with the mains quiz. Myself, Dr. Sandeep Sharma. I'm MD Pediatrics from PGI Chandigarh. I'm DocTutorials faculty for pediatrics. And this is myself as well as my team who have prepared this quiz. So let us begin with the quiz first of all. So what are the rules we are going to follow here? So rules of the quiz, first of all, there will be total 6 rounds with some rounds having 2 sub rounds each. That is, there will be sub parts in each round. Additional tiebreaker round will be used if the scores get tied. Time per round will be told before the beginning of each round. Score of each candidate at the end of each round shall be announced. No use of unfair means shall be allowed. And for that, we have ensured, I know nobody is going to do that. All of you are sincere people, but at the same time, there is a time limit for answering the question. So even if you answer it after time limit has gone, it is not going to be beneficial. There will be no passing of question, and no negative marking will be there in the rounds except tiebreakers. And tiebreaker question, if used, shall have negative marking. If there is a time lapse due to a network issue, to extend time or not, that will be my call, along with a call of the administrators who are in the background just listening to this. So that a call we can take later on. And in case of any doubts or conflicts, the decision of the quiz master shall be final and binding. So I'm the face of quiz master, but there is a team behind me. So it will be the final and binding thing. So let us begin with the round 1. Round 1 is going to be the neonatology round. A child is not a miniature adult, and all the more true for a newborn. So newborns, there are a lot of questions which are asked in your exam. If you look at your MBBS final year, if you look at your internship, and if you look at your entrance exams, you will find that there is always 1 to 3 questions from neonatology. And in neonatology, the most important thing is neonatal resuscitation. Neonatal resuscitation, you will get questions. These things, the questions which I have framed here, they will be beneficial for you in a quiz format also, in your vivas also, and they will be beneficial for your entrance exams as well. Each question will have 2 parts. Answering one part will give you 5 numbers. Both, if you answer it, it will give you 10 marks. There is no negative marking. Total time per question will be 60 seconds, right? So full 1 minute you can think and then give the answer. So let us begin with question number 1 is for Dr. Arman. So the stopwatch starts now. This is your question. Look at the self-inflating embu bag shown in the picture and answer the following questions. If you can see, there is a red mark which has been put. What is the name of the structure pointed with the red arrow, and at what pressure does it open up? Only when I have said it out aloud the question, then only your time will start. So your time starts now. Dr. Arman?
Yes, sir. The name of the structure is the fish mouth valve.
Okay.
And sir, it opens up at a pressure of 50 centimeters of water.
Okay. Anybody wants to differ from Dr. Arman? Anybody wants to differ or give another answer here?
Sir, a pop-off valve and 35 to 40 centimeter water.
Of?
Water.
Of water. Yes, that is saline. So the answer to this question, it's a self-inflating embu bag. The pointed structure which has been shown is pressure release valve, also called as pop-off valve. And these valves are usually said to release at 30 to 40 centimeters of saline, right? So Dr. Arman, where did you get it wrong?
Sir, isn't the fish mouth valve the same as the pop-off valve?
See, the fish mouth valve is different, and fish mouth valve is not the proper terminology. In fact, fish mouth valve, somebody wants to clarify to Dr. Arman? Anybody wants to volunteer? See, the fish mouth valve which is there, that is the common terminology that we use for these fish, for these bags. Certain times fish mouth basically we say because there is a fish-like structure which is present in the embu bag. The answer to this question is, so we were talking about question number 1 with candidate Arman. Arman, This is not fish valve. This is pressure release valve, also called as pop-up valve. Fish valve is a pseudo term. It is not a scientific term, which is sometimes used for a valve-like structure which is present here. Now, if I have to show you this picture, can you see in this image that there is something like this is the valve which I had shown you, right? This is the pop-up valve. The purpose of this is when you are giving pressure, if it exceeds beyond 30 to 40 centimeter of saline, it opens up and allows the pressure to get released. The purpose of fish valve is whenever you apply pressure, there should be unilateral entry into one side so that the two parts, they approximate with one another and only open in one direction. That is called as a fish valve. If you have to talk about the so-called fish valve, if you see from in an actual embo bag, it will appear somewhere over here. If you see from that side, there is a valve-like structure present, which is called as fish valve. In the new embo bags, which are now commercially available, the valves are designed in such a way that fish valve is actually not present. It is only the older bags, the green colored bags, which are there in medical colleges, where you may still find fish valve to be present. So this is a pop-up valve. This is not a fish valve that is being talked about, but the pressure which you mentioned was on the correct side, so you get +5 in this question. So Arman gets +5 in question number 1. Moving over to question number 2, let us talk about question number 2, and question number 2 goes to Dr. Ibrahim. Dr. Ibrahim, here is your question. A baby is born through meconium stained liquor. As you can see in the image, what are the features to define a vigorous baby? Number 1. And if the baby is non-vigorous, what next is to be done? I'm turning on the stopwatch now.
Sir, a vigorous baby is one which has a good tone, who has good tone, who's crying, who is active. And if he is not vigorous, in that case, sir, earlier we used to do suction, but now it is not recommended. We go for endotracheal intubation.
You go for, and what is the next step to do?
Sir, we give positive pressure ventilation first, and then if that doesn't work, then.
Correct. So would you like to define? You still have 30 seconds to go. You have only taken 30 seconds. You haven't answered the first part correctly. You have mentioned one part, but there are multiple features.
Tone is good. Moving limbs. One who is.
Try to think what all things we assess in a newborn.
So in that we assess whether it is term, crying, and tone. The baby is term, whether he's crying and he has good tone. That is general.
Crying is not a criteria, color is not a criteria, and your 1 minute is over. So yes, your second answer is correct. See, whenever this is a very, very important thing, and expectedly MCQ on this can also be asked. Guidelines have now changed. Whenever a baby is born through meconium stained liquor, there are, first of all, we see whether the baby is vigorous or not. What is a vigorous baby? We look for 3 parameters: heart rate more than 100, good respiratory effort, and good muscle tone. Correct? So if all 3 are present, we call it as vigorous baby. Any of them missing, that is a non-vigorous baby. In a non-vigorous baby, next step to do is the routine steps. Earlier, what we used to do was we would do oral suction, we will do nasal suction, and then, we will do intubation directly. Bag and mask, PPV used to be avoided. But these days, bag and mask ventilation is allowed to be done in meconium stained liquor. So what are the points you should remember? In MSL babies, vigorous babies, heart rate more than 100, good respiratory effort, and good muscle tone. And secondly, if non-vigorous, you give initial steps under radiant warmer and you start with positive pressure ventilation. How to give PPV? The guidelines have left it to the treating physician. You can do bag and mask, you can do intubation. So examiner will not ask you to call on this, but if they ask you, is bag and mask ventilation contraindicated in meconium? It is no longer contraindicated. There is a difference. You need to understand the difference, right? So Ibrahim also gets +5 in this question. Let us move to question number 3. Okay, Prabhupada, here comes your question. Question number 3. Look at the procedure being done in neonatal resuscitation. And what is the procedure? Secondly, what is the use of this procedure? So let us start with the first part. What is being done here? Prabhupada.
Umbilical vein catheterization.
Excellent. Correct.
We give, it used to give IV epinephrine.
Yes.
And IV epinephrine, and then the 3 ml of normal saline for.
Normal saline can be given. in case the child is having hypovolemia. So absolutely right. Answer to question number 3. Prabhupada has answered absolutely right. So you get plus 10 on this. So this is umbilical venous catheterization, which is being done. Look at this catheter. Can you see that there are black markings on this? So this is a catheter and it is being inserted into umbilical vein. We don't do umbilical artery catheterization except some circumstances. You need to take blood sampling. For procedure to give something, we always do umbilical venous catheterization in newborn. So this is umbilical venous catheterization. The indication says it is the fastest way to give epinephrine or any IV fluid during neonatal resuscitation. You can give fluids, you can give drugs, you can even give blood transfusion, but you can give only during neonatal resuscitation, not beyond that. So Prabhupada answers, gets plus 10 on this. Next is question number 4 goes to Ribhav. Ribhav, look at the question now. Intubation is being performed in a neonate during neonatal resuscitation. What type of blades of laryngoscope are used, straight or curved? And name any 2 indications of intubation in a neonate. Your time starts now.
Sir, there can be two types of possible blades. In children, we generally use straight blade, I believe. The straight blade and the 2 indications are, sir, if we think like if the bag and mask ventilation is contraindicated, like in CDH, or in case like we need prolonged bag and mask ventilation for a child. Correct. In that case.
Absolutely right. Absolutely right. These indications are also mentioned in UPGHI. They are very frequently asked. Can you name the straight blade? What is the name of straight blade? What is it called as?
The straight blade, I believe the straight blade is, I think, the Miller blade, and the curved one is the Macintosh.
Okay. Let us have a look at what Ribhav correctly answered. Ribhav gets plus 10 on this. So the points to mention here, there are 2 types of blades used in intubation, the straight blade and the curved blade. Straight blade is also called as Miller's blade. Curved blade is also called as Macintosh blade. Remember that straight blades are useful in infancy. So first year of life, only straight blades are to be used. 1 to 5 years depends upon the child, depends upon the airway. Above 5 years, always curved blades are to be used. If you remember this point, you will never go wrong. So always curved blades in adults or older children, always straight blades in infants and newborns. And second thing, what are the indications of intubation? When prolonged BMV is needed, you have given for more than 30 seconds, more than 1 minute, now child improve ho raha hai, now the child is deteriorating, you need to intubate. Secondly, when bag and mask ventilation is ineffective, for example, heart rate is less than 60 per minute, despite positive pressure ventilation. Thirdly, diaphragmatic hernia, where bag and mask ventilation is contraindicated. And so these are indications. Other than that, in case you want to give mechanical ventilation, then also you will have to intubate the child. That is not mentioned in GHI, but remember, any ventilation, except it is non-invasive ventilation, any invasive ventilation will require intubation of the child, irrespective of age, right? So Ribhav has got it correct. And next we move to Dr. Satish. Dr. Satish.
Straight blade is preferred in neonate than curved blade.
See, it is related to the angle and the anatomy of the newborn. In newborns, what we find is when you try to intubate, the positioning, when you see, what we do is whenever we have to intubate, we put the child in a neutral position. Neutral means the neck should not be flexed, it should not be extended. The so-called sniffing position is maintained. That is the ideal for intubating the child. When you put in a straight blade, you find that the anatomy of a newborn neck is such that the moment you try to enter and you lift the structures, directly you will be able to visualize. As age advances, a curvature of neck comes. If you compare to your neck with a newborn's neck, newborn has a short and straight neck. Whereas in you and me, there is a slight curvature which comes into play. And so you need to have a curved blade according to the anatomy. It is a necessity based upon the anatomy of a person rather than there being a definite physiological reason for that, right? Moving to question number 5 for Dr. Satish. Dr. Satish, here
Yes,
comes
sir.
the question. I'll be speaking the question, then your time will start. So you can read the question simultaneously, listen to me. Question number 5. This is your question. Look at the image. What is the target preductal saturation? This is a SpO2 probe which has been attached, obviously. So at 1 minute of life, what is the preductal SpO2? And second question is, where is the pulse oximeter probe attached to measure preductal SpO2 in a newborn?
Targeted preductal SpO2 1 minute is 60 to 65%.
Okay.
And for checking preductal SpO2, we need to put probe at the right side of the upper limb.
Okay. Excellent. You have answered correctly. Any reason why we attach it on the right upper limb only?
Because in the left side, ductus arteriosus is connected distal to the left subclavian artery. So that will cause us, after distal to that, there will be some sort of deoxygenated blood. Proximal to that, there will be oxygenated blood. So preductal SpO2
absolutely rightly answered, and you get +10 on this. So what are the key points to remember? First of all, these are the target preductal saturations after birth. You need to remember them as one-liners. They are asked in your vivas. They are likely to be asked in your MCQ entrances also. So at 1 minute, it is 60 to 65%. Then by 5%, it keeps on rising till 5 minutes. And at 10 minutes, it is 85 to 95%. And to check preductal SpO2, it is always attached in the right upper limb. All the other limbs, there is a possibility of ductus arteriosus having a bidirectional flow and producing a abnormal reading. So we always attach in the right upper limb. But this is only true for newborns. Once the ductus arteriosus is closed, you can attach to any part of your body and get almost similar reading. So concept of preductal SpO2 is only in case of till ductus arteriosus is not closed. So next we move to question number 6 for Dr. Shagun. Dr. Shagun, here comes your question. Question number 6. During neonatal resuscitation, chest compressions are being administered. What is the recommended depth of compression? Number 1. And number 2, what is the ratio of chest compression to ventilation? And your time starts now.
So the recommended depth of compression is 1/3 of the AP diameter of the chest. And the ratio of chest compressions to ventilation is 3:1. There should be 90 to 30, total 120 events.
Excellent, excellent, absolutely rightly answered. So Dr. Shagun gets +10 on this. So the recommended depth of compression according to NRP guidelines is about 1/3 of the AP diameter of the chest wall, and compression to ventilation ratio varies in different age groups. Please remember that. So in newborn period, there in 1 minute, you should be giving 90 compression and 30 ventilation. So 3:1 is the ratio. Total number of events will be 120. There is an old MCQ where they ask, what is the total number of events? When they say event, it includes both compression and ventilation, and the answer will only be 120. It is a very old MCQ, older even than me when I used to be a student, but any MCQ is a possible repeat MCQ. So at the end of round 1, everybody has scored at least, you all have opened your accounts. 2 of them have got +5, the other 4 have got +10, and evidently all of you are very well prepared. So I think there will be a need for tiebreaker also. So let us move to round number 2. Round number 2 will be related to syndromes. Each question, you have to just give the answer to that question. There is no +5, +10. You get either full number or no number. And total time per question will be half of this because it's a one-liner based round. You have to see, read, and give your diagnosis. So total time per question will be 30 seconds. Don't worry, I'm not going to ask Down, Edward, or Patau syndrome because I know all of you know them. So there will be other syndromes related to that. Let us begin with, first of all, Dr. Arman. Dr. Arman, here comes your question.
Yes, sir.
Question number 1. Look at this question. Child born with receding chin was intubated and also had limb anomalies. There is a history of oligohydramnios in the mother. Look at the image and tell the likely syndrome along with the image. Your time starts now.
So the answer is Porter syndrome due to oligohydramnios.
Excellent.
And it
Excellent, excellent. That is all I needed. More you want to elaborate, you're most welcome.
Associated with usually with renal agenesis or with other obstructive uropathies.
Yes, correct, correct. Why does it happen? What is the pathophysiology?
The pathophysiology, the basic pathology is usually renal agenesis associated with the pathophysiological process, which is oligohydramnios. So the baby usually, the lungs are filled with the amniotic fluid. So if there is oligohydramnios, then the lungs, there will be pulmonary hypoplasia, and the face and limbs will be pressed upon by the mother's abdominal wall structures, and hence the face will be flattened, the chin will be pushed inside, and there will be limb defects.
Very impressive. Excellently answered. I don't think anything is from my side to be added. So as Dr. Arman rightly said, it is Porter syndrome, and it arises due to oligohydramnios as it is seen in bilateral renal agenesis, and the cause of death, which is a AIMS MCQ already asked in the past. pulmonary hypoplasia is the cause of death. Children do not die due to oliguria or absent urine. They die due to pulmonary causes. 85% cause of death is pulmonary hypoplasia. Only 15% children die due to other involvements, including renal involvement. So this is the answer to question number 1. So Arman has scored well. Question number 2 goes to Dr. Ibrahim. Dr. Ibrahim, here comes your question. A child is born with small receding jaw, cleft palate, and has glossotosis. And you can have a look at the image also. Name the likely syndrome.
So it seems to be Pierre Robin. Pierre Robbins.
Yes, Pierre Robbins. Absolutely right. So Pierre Robbins, anything else you want to add here? It says a classic triad already mentioned here. So Pierre Robbins syndrome, there is micro plus retronathia, chota jaw, but receding also. There will be cleft palate and there will be glossotosis in the patient. Pierre Robbins syndrome is also called as Pierre Robbins sequence, associated with a lot of other syndromes, can also be an isolated anomaly. Moving to question number 3, which goes to Dr. Prabhupada. Dr. Prabhupada, here comes your question. A male child with coarse facies, hepatosplenomegaly, corneal clouding, and has joint contractures. What is the likely syndrome? The face of the child is also shown here. Dr. Prabhupada, your time starts now.
Sir, mucopolysaccharidosis.
Which one? Syndrome. You have to name the syndrome. 4 seconds. 3, 2, 1. The time is over. You need to name the syndrome. Anybody wants to volunteer on this now? Yes, absolutely right. Sometimes the name just does not come to our mind. You were right, but it is Hurler syndrome. You need to name the syndrome. Hurler syndrome, it is type 1 MPS. So what is the difference between Hurler syndrome and Hunter syndrome? It's one of the favorites of...
So corneal clouding is seen in Hurler syndrome and not seen in Hunter.
Yes. Any other?
X-linked.
Yes. Inheritance. Third thing, it is a male child. So male, both babies can be there. Age of onset. Remember, age of onset is very important. Patients of Hurler syndrome will always come to attention before 6 months of age, whereas Hunter syndrome usually comes to attention between 2 to 4 years of age. This fact is mentioned in multiple textbooks. In 2018, there was a question in AIIMS also based upon this particular fact. So what are the key points about this that you need to know? Hurler syndrome, that type 1 is also called, there is a milder version of this also called as Shea syndrome. So we call it as 1H and 1S. Enzyme deficiencies, alpha-L-iduronidase. Hurler syndrome is the most severe form, and onset, as I said, 6 months to 2 years. These children have coarse face, obesity, sleep apnea, developmental delay, hepatosplenomegaly, joint contractures, dysostosis multiplex, and corneal clouding. On the other hand, type 2 Hunter syndrome, it will be similar to Hurler syndrome, but it is X-linked recessive. Onset is 2 to 4 years and no corneal clouding. If you remember these 3 features, which are differentiating Hurler and Hunter, all your past MCQs will always be correct. So remember these 3 points, and you can later on, once this video goes live, you can also add it to your notes. So Prabhupada, unfortunately, doesn't get credit here, but there are still more questions to go, so no worries here. Now, Dr. Ribov, question number 4. Here comes your question. A male child with hypertelorism, low set rotated ears, small jaw, hypocalcemia, congenital heart disease. Image has been shown. What is the likely syndrome?
Sir, this is, I believe this is Dye-George syndrome.
Why do you say so?
Sir, because the features, the hyper...
You're taking a calculated risk here. It's okay, your 30 seconds are already over.
I don't know. My answer is Dye-George syndrome, sir.
Okay. The answer is correct, but you should know why it is so. Abnormal facies, congenital heart disease, hypocalcemia. Hypocalcemia is a big clue here. Dye-George syndrome, what are the key points that you need to know? Dye-George syndrome is caused by microdeletions in chromosome 22q11.2. Clinical features are given by the mnemonic catch-22. Now the term catch-22 is no longer used because we know that one component is not present even in 50% patients, but still it is a part of Dye-George spectrum. So cardiac defects, wrong thing mentioned in many guides. What is the most common congenital heart disease? All standard textbooks are very clear. It is interrupted aortic arch syndrome, followed by truncus arteriosus, followed by tetralogy of Fallot. There is a guide in the market which says it is TOF. It is not TOF. TOF is the third most common. Then abnormal facies. These children have thymic hypoplasia leading to T-cell defect because there is maldevelopment of the bronchial arches. Cleft palate may or may not be present. And then you have hypocalcemia, which is the presenting sign in the newborn period. Please remember that. If they ask you what is the presenting sign, the answer will always be hypocalcemia. So, Ribab, you get the answer correct. You get +10 on this.
Sir, is there any pathognomic feature out of these for an MCQ?
No, there is no single pathognomic feature. It is always a combination. In syndromes, it is always a combination, and that is why the whole clinical picture needs to be seen at. You have posteriorly rotated ears, which can be seen in multiple conditions. If you see in this child, there is receding chin and there is hypertelorism, but that again can be seen in multiple syndromes. So when you have abnormal face with cardiac disease, with hypocalcemia, then you have to think about Dijon syndrome. Next is Dr. Satish, here is your question. Child with limbs as shown having the abnormality in the ECG and also has atrial septal defect. What is the likely syndrome? Your time starts now.
So this is Holt-Oram syndrome.
Great, excellent. Holt-Oram syndrome. Not a part of this question, but can you tell the gene involved?
TBX5 gene.
Excellent. Inheritance?
Autosomal dominant.
Yes. You just answered a super specialty MCQ of pediatrics NEET just now. They had asked about inheritance. Holt-Oram syndrome has already been asked in multiple PG entrance exams. And what are the key points about this that you need to know? Autosomal dominant has TBX5 gene mutation. TBX5 is a part of homeobox genes, which are involved in right-left orientation as well as in deciding the length of various structures. It is characterized by a triad of limb hypoplasia, ASD, and cardiac conduction defects like heart block. So if you have to talk about two common causes of heart block or congenital heart block, one is Holt-Oram syndrome, second is maternal SLE. Mother SLE causes heart block in the child. So these are two common causes that you need to remember. Moving to Dr. Shagun. Dr. Shagun, question number 6 comes now. A child with craniosynostosis, bilateral syndactyly, and midface hypoplasia, the likely syndrome. Time starts now.
Apert syndrome.
Excellent. Why do you say so? Because there is syndactyly and there is craniosynostosis. So that answer is absolutely right. The answer is Apert syndrome. In Apert syndrome, there is gain of function missense mutations in FGFR2 gene. It may be associated with advanced paternal age. We all through our life, we keep on remembering the causes of advanced maternal age, but nobody thinks about father also. So this is one syndrome which association with advanced paternal age. Not all patients will be having advanced paternal age, but one association of advanced paternal age is Apert syndrome. And it is characterized by a classic triad, craniosynostosis, midface hypoplasia, and bilateral syndactyly. Differences between Apert and Cruzen syndrome must be remembered for your INI CET entrance exam. Please remember that. So at the end of this round, at the end of round 2, Dr. Shagun, Dr. Satish, Dr. Ribab, all three are having a score of +20. And Dr. Ibrahim, Arman are catching up, and Dr. Prabhupada is also, he could not score in this round, but now you have a chance to make up in round 3. Vaccines will be there, and now again 2 parts will be there. So you can, if you answer one part, you still get the credit for that. So because there are 2 parts, so the time allowed will be 60 seconds. So let us begin with Dr. Arman. Dr. Arman, your question comes now. MR vaccine is a part of the national immunization schedule. Part 1 question is, what is the strain for rubella? And part 2, when is the second dose administered?
So the strain is RA27 strain, and the second dose is administered at 16 to 24 months.
Okay.
Along with MR2. The first dose is at 9 months, second is at 16 to 24 months.
Excellent. And so what are the key points we need to know? It is a live attenuated vaccine. Measles strain is at Boston Zagreb strain. Rubella strain, the correct word is Vistar RA273. You have to remember that. Vistar word is missing from some of the textbooks, but the original strain is Vistar RA273. And the second dose of MR is given at 16 to 24 months, as rightly said. So you get +10 on this. Moving further, question number 2 goes to Dr. Ibrahim. Dr. Ibrahim, this is your question. Regarding BCG vaccine, what is the dose if given in a child aged 21 days? And secondly, BCG vaccine has good protective efficacy against which types of tuberculosis in children? Your time starts now.
So 21 days means less than 1 month. In that, we give half the normal dose. Normally, we give 0.1. In this, we give 0.05 intradermal. And in BCG vaccine, it does not have efficacy against just pulmonary tuberculosis. That's up to 80% efficacy against the severe form of tuberculosis.
No, question is asking which has good protective efficacy against what type. It does not have good efficacy against some types. It has good efficacy, proven efficacy against certain types. So you have to name the conditions where there is good protective efficacy. You still have 30 seconds to go.
TB meningitis.
TB meningitis.
Is disseminated in severe TB.
Correct. Excellent. So you get +10 on this as well. So regarding BCG vaccine, it is given intradermally. Dose is 0.05 ml up to 1 month and 0.1 ml thereafter. What is the maximum age up to which BCG vaccine can be given?
We give to 1.
Up to what age? Unvaccinated child comes to you and you will say now you don't need BCG. What is that?
In NIS, it's up to 1 year.
It is not 2 years.
In NIS, it is 1 year.
It is 1 year. In NIS, it is 1 year. Then BCG vaccine provides good protection against TB meningitis as well as disseminated or miliary tuberculosis. Its protective efficacy in pulmonary TB is between 0 to 40%. In certain patients, it is 0% as well, right? So you get +10. Next, we move to Dr. Prabhupada. Dr. Prabhupada, here comes your question. Question number 3. Regarding pneumococcal conjugate vaccine in National Immunization Schedule, number 1, what is the route of administration? Number 2, what is the schedule recommended in NIS? And your time starts now. Dr. Prabhupada?
Sir, route is IM.
Yes.
And so schedule is 6, 14 and 9 months.
Almost correct. It is 9 to 12 months. So absolutely right. You get +10 on this. Pneumococcal conjugate vaccine, what are the key points you should know? PCV13 vaccine has been introduced in the NIS. Route and dose is 0.5 ml intramuscular in anterolateral mid-thigh. Schedule says 2 primary doses at 6 and 14 weeks, then a booster at 9 to 12 months. It differs from the IAP schedule. In IAP schedule, it comes at 6, 10 and 14 weeks, and then there is a booster at about 16 to 18 months. So there are differences between NIS and the IAP schedule when it comes to pneumococcal vaccine. Which type of pneumococcal vaccine is no longer available? Just asking. Anybody wants to volunteer? Yes, 7-valent vaccine. Excellent, Dr. Shabul. PCV7 has been abandoned. It is no longer available anywhere. PCV10 is the other form, but PCV10 was not chosen. In private sector, PCV10 is still available. It comes by the name of Synflorix. Moving further, we move to Dr. Ribhav. Question number 4 comes to you now. Regarding IPV in National Immunization Schedule, what is the route of administration? And secondly, what is the schedule recommended for the 2 doses?
Sir, the route is intradermal, which is given in the upper arm, and it is given, I think, in NIS it is 6. It is given at 6 and 14 weeks of age, I think. Okay. 2 fractionated doses.
Okay, good. So fractionated doses are useful. So IPV vaccine, fractional doses are recommended in National Immunization Schedule. Route and doses 0.1 ml intradermally into the right upper arm. Schedule says 2 primary doses at 6 and 14 weeks, then a booster at 9 to 12 months. I just want to ask, why fractional doses? What was the reason for fractional doses? And why not the complete dose? Complete dose is given in IAP schedule. What was the major reason?
Economically better, can cover more people through the IPV.
Excellent, excellent. It was basically for economic consideration. There were 2 big randomized trials. Both of them showed that if you give a single 0.5 ml intramuscular dose, on the other hand, you give 0.1 ml, 0.1 ml separated by about 10 to 14 weeks, their efficacy is equivalent. And in fact, it is almost 50% cheaper when you give as a fractionated dose. Because of this, it was recommended that in NIS, we should give fractional doses. But it is assumed that once our country improves, once the IPV cost comes down, there may be a decision in future. We don't know about now, but in future, there may be a decision where the dose recommendation may change. In private sector, in IAP, we do not give fractional doses. We give normal 0.5 ml dose. That is the intramuscular dose which is given. So moving further, Ribhav also gets +10 in this. Dr. Satish, question number 5 comes to you. Here is your question. Regarding pentavalent vaccine in National Immunization Schedule, what is the maximum age up to which it can be administered? And second, what is the difference between pentavalent and the DPT booster given after 1 year of age?
Sir, pentavalent vaccine can be given up to 1 year of age. Then difference to the pentavalent and DPT. Pentavalent.
Basically, what is the difference between pentavalent and DPT?
Pentavalent has additional 2 vaccines, Haemophilus influenza and hepatitis B.
Yes, correct. So you get +10 on this. So rightly answered. Pentavalent vaccine, 3 doses at 6, 10 and 14 weeks. Dose is 0.5 ml. Intramuscular can be maximally given up to 1 year of age. Difference is that Hib and HBV are additionally present in pentavalent vaccine, right? So remember, there are 2 vaccines which cannot be given beyond 1 year of age if not given before. One is pentavalent, second is BCG. MCQ scenario-based thing already asked in AIMS entrance exam some years back. So we move to Dr. Shagun. Dr. Shagun, question number 6 comes to you now. Regarding Japanese encephalitis vaccine, is it a part of National Immunization Schedule? You just need to answer yes or no. And second, dose, if it is there, what is the dose and timing of JE vaccine?
Sir, it is a part of the NIS in certain states where JE is endemic, and it is given along with the MI vaccine only, subcutaneous route, 0.5 ml subcutaneous. The JE first dose is given at 9 months, and the second dose is given along with the second dose of MR at around 16 to 24 months.
Excellent, excellent, excellent. So JE vaccine recommended only in endemic areas. Regime, route and dose. First dose given at 9 to 12 months, second dose at 16 to 24 along with MR vaccine in endemic areas. And 0.5 ml is the dose. For live attenuative vaccine, you give it subcutaneously. For killed vaccine, the route is different. Please remember these points. So round 3 is done. Now we'll be moving into round 4, milestones round. Again, each correct answer will get you 10 marks. Total time per question will be 30 seconds. Answer cannot vary beyond 4 weeks. In milestones, there is always a range. And so plus minus 4 weeks will be allowed. Beyond that, it will not be allowed. The references used will be Opigai, Nelson, and Illingworth. Anything other than that does not count. So let us begin with question number 1. Dr. Arman, here is your question. When does the following milestone first appear?
5 months.
Excellent. So this is child putting toes in mouth in supine position, also called sucking on great toe, appears at 5 months of age. You get +10 on this. Question number 2 goes to Dr. Ibrahim. When does the following milestone first appear?
Sir, this is I can't see if it is on the other side images. If it's unidextrous approach, it appears at 5 to 6 months. But if he's doing some pincer thing, then it is 9 to 12 months. I can't see in this image whether he's moving or the other side he's holding something or not.
Basically, he's looking at his hand.
Hand regard is at 2 to 3.
At 2
to 3 months.
2 to 3 months. Okay. First appear it is asking, and since 4 weeks ka allowed hai, so you get the answer correct. This is hand regard. This is hand regard, which the child is looking intently at his own hands. That is called as hand regard. It is a part of normal development, appears at 12 weeks, disappears at 20 weeks. Right? So it persists between 3 to 5 months of age. Any child with persistent hand regard beyond 5 months, you should evaluate for some neurological disorder. Very interesting thing, hand regard occurs even in blind children. So it is not related to vision. It is not related to a visual thing. It has been shown to occur even in blind children, right? So it is a well-established fact which is mentioned in books. It is a part of the normal development of the child. So you get +10 on this. Next, we move to Dr. Prabhupada. Dr. Prabhupada, here is your question. When does the following milestone first appear? Your time starts now.
Sir, 10 months.
What is this child doing actually?
8 months. 8 months crawling. So the abdomen is...
Great. You did it just within time. So it is crawling. What is the difference between crawling and creeping?
In crawling, the abdomen touches the floor, but in creeping, the abdomen is lifted off the ground, and the child uses all the 4 limbs to
There is a
Wow.
gap of about 4 weeks between the two milestones. So this is crawling, appears at 8 to 9 months of age. Creeping comes 1 month later, that is 9 to 10 months of age. Crawling, abdomen is touching the ground. Creeping, it is lifted above the ground. So excellent, you get +10 on this. Dr. Ribov, here is your question. When does the following milestone first appear? Your times has been started.
Sir, the child is, I believe this is teething. I'm not very sure. I guess it appears by 6 to 8 months, I think, when the first eruption of the teeth starts.
Okay. Anybody wants to differ on this?
So this is mouthing appears at 4 to 6 months.
Yes. So this is mouthing, this is not teething. There is no such milestone as teething. Teething is a generic term which is used, which we say there is eruption of teeth. Eruption of teeth can happen anywhere between 6 to 12 weeks, 6 months to 12 months. And if it does not appear by 13 months, we call it as delayed eruption. Teething is not a milestone. Teething is a phenomenon. This is mouthing of objects which appears between 4 to 6 months of age. And that is why this is the time during which children have a tendency to aspirate foreign body as well. So if you look at old MCQs, there was one MCQ they would ask, what is the peak age of aspiration of foreign body? The answer to that is 6 to 9 months. The reason for that is 4 to 6 months, the child will start mouthing, and immediately after next 3-4 months, he will have a tendency to aspirate coins, buttons, and all these things. So it correlates with foreign body aspiration, right? So Ribhav, unfortunately, you don't get credit here. Moving to question number 5, Dr. Satish. When does the following milestone first appear?
Sir, this is smiling at mirror, that is 6 months.
Almost correct. Yes, the range is 5 to 6 months, right? There are two types of mirror milestones. One is smiling at mirror image. Second is playing with his own mirror image. And there is again a gap of about 4 weeks. Smiling appears about 5 to 6 months, and playing with his own mirror image comes 4 weeks later. So this is playing with his own mirror image appears at 5 to 6 months of age. So absolutely right. Dr. Satish gets +10. Dr. Shagun, when does the following milestone first appear?
So this is the pincer grasp. The immature pincer grasp will appear around 9 months and it will mature at 12 months of age.
Excellent. Why do you call it as immature?
So because initially the child tries to pick it up with the entire finger, and later when it matures, he only uses the tips of the finger.
Yes, correct. So this is, the child is holding objects using thumb and index finger, but not at the end of digits. This is called immature pincer grasp, appears at 9 months. Mature pincer grasp comes at 12 months of age. Examiner does not tell. He simply says, what is the normal time of appearance of pincer grasp? What will you answer? It's a very controversial thing.
First appears at 9 months, so should be 9 months.
That is the incorrect thing. That is the mistake we make. See, when I say a newborn is in front of you, would you say it is a term neonate or would you say it is a preterm neonate? We assume it is a normal thing, right? We assume it is a term neonate. So when we say a pincer grasp, we assume that this is a mature pincer grasp unless the word immature has been mentioned. Immature pincer grasp does not always come in all children. Certain children, they directly move to mature pincer grasp and start picking around 12 to 13 months of age. This was a very controversial question asked many years back when I was a student. And at that time, I did not know the answer. Later, I moved into residency and I asked one of my professors who is now retired, but she has been an icon in the field of neurology. And she gave me this analogy, which I'm sharing with you. So, हर चीज MCQ नहीं है, but certain things just always help. So, Shagun has got it correct. So, Dr. Shagun, you get +10 on this. So 4 rounds are done. Now we move into round number 5. And this is the clinical scenario rounds. Each correct answer will get you 10 marks. Because it is a scenario, you will have to read question and there will be options mentioned here. So it is a kind of MCQ round, you can say. So 4 options, you have to pick one answer among the diagnosis which is being asked. So let us begin with Dr. Arman. Dr. Arman, here is your question. Question number 1. A preterm neonate has visible jaundice on day 24 of life. Which among the following cannot be the reason? RH incompatibility, physiological jaundice, breast milk jaundice, extrahepatic biliary atresia. Your time starts now.
So physiological jaundice.
Okay, it's fine. You have answered it absolutely right. The answer is physiological jaundice. Physiological jaundice, by definition, will not persist beyond 2 weeks in term and beyond 3 weeks in preterm. This is a preterm child. Any jaundice beyond 21 days in a preterm will always be pathological. And you need to find the reason for that. It can be RH incompatibility, it can be breast milk jaundice, it can be extrahepatic biliary atresia. There is an important table that you need to remember related to the causes of prolonged jaundice beyond 2 to 3 weeks. The common causes include inadequacy of breastfeeding. Second is breast milk jaundice. Third is cholestasis. Fourth is continuing hemolysis like RH, AB, and B6PD hemolysis. Rare causes include extravasated blood like cephalohematoma, hypothyroidism, Crigler-Najjar syndrome, GI obstruction like malrotation, and Gilbert syndrome. Now, if you have to pick which is the overall most common cause of prolonged jaundice, what will be your answer? Anybody among these?
Breast milk jaundice.
Not
jaundice.
It will be inadequacy of breastfeeding, also called as breastfeeding jaundice. They have not mentioned it as breastfeeding jaundice, but there is a difference between them. Breastfeeding jaundice is due to less
dehydration.
It causes dehydration, increased enterohepatic circulation, right? Breast milk jaundice is deconjugation. It is relatively 10 times rare compared to breastfeeding jaundice. So overall, most common cause will be inadequacy of breastfeeding. So you get +10 on this. Question number 2 goes to Dr. Ibrahim. Dr. Ibrahim, here is your question. Newborn presents with respiratory distress and frothing from mouth on day 1 of life. The baby cyanosed. What could be the most likely cause? Lung hypoplasia, congenital lung cyst, esophageal atresia, diaphragmatic hernia.
Sir, esophageal atresia, most likely he has a tracheostomy fistula with his eyes having frost.
I can't hear you. Your voice is breaking.
Esophageal, option C. Option C.
Option C is absolutely correct. Remember that whenever you have a newborn with frothing from the mouth, this is because the newborn cannot swallow his own secretions. So there will be esophageal fistula with esophageal atresia in the newborn. If the child is having scaphoid abdomen with mediastinal shift, you will think of diaphragmatic hernia. So absolutely right. You get +10 on this. Question number 3 goes to Dr. Prabhupada. Dr. Prabhupada, here is your question number 3. Child with suspected celiac disease underwent upper GI endoscopy followed by a biopsy. His biopsy finding will include all except. Your time starts now. Dr. Prabhupada.
Sir,
60 seconds. Abhi sirf 10 seconds hua.
Sir, C, thick jejunal mucosa.
Absolutely right. You get +10 on this. Any specific reason for this? Or you just ruled out other options?
Yes, sir. I ruled out.
Yes, correct. There are 2 ways of reaching the same destination. You can either know the correct answer or you can rule out other options. So absolutely fine. See, patient with celiac disease will have a thinning of the mucosa, right? Because mucosa is getting degraded, it is getting destroyed. So it will not be a thickening. So what are the features that will happen in patients of celiac disease? There will be subtotal to total villus atrophy. There will be increased intraepithelial lymphocytes in gastric mucosal epithelium and submucosa. Crypt ज़्यादा हो जाएंगे, villus छोटा हो जाएगा. So there will be alteration in the villi to crypt ratio. Blunted or atrophic villi will be there, and there will be mononuclear cells coming in the lamina propria. Not a part of this question, but open to everyone. Suspected patient of celiac disease clinically. What is the first investigation to perform? According to latest ISFAGAN guidelines 2021. Clinical diagnosis suspected. Screening test karna hai, which is the investigation to perform.
Sir, a stool fat test to check for.
No, stool fat test has low sensitivity.
Anti-TTT.
Anti-TTG.
Are you sure, or you want to add something?
IgA anti-TTT.
That is partially correct, not totally correct. According to ISFAGAN guidelines, any patient with clinical suspicion of celiac disease, you need to perform. The first line investigation is combination of IgA TTGA along with total serum IgA. Why is it needed? 5% patients of celiac disease have low serum IgA, and because of that, they miss the diagnosis and come to attention late in life. So new ISFAGAN guidelines have very clearly said it is a combination. Both should be done, TTGA with total serum IgA. This could be a potential MCQ for your exam. Please, especially if you're targeting INI-CET, go through the diagnostic algorithm which is there. In case you have a difficulty in finding or you find it too tedious, I'll share handmade simplistic form of that with all of you, right? So Dr. Prabhupada gets +10 on this. Let's move further. Question number 4. Dr. Ribab, this is your question. 4-year-old child presented with abdominal pain, which was acute in nature, vomiting, progressive lethargy. There was red currant jelly stools, contrast edema revealed coiled spring sign. What is the likely diagnosis?
Sir, interception.
Okay, a relatively easy one. The answer is correct.
Red currant jelly stools were the giveaway.
Most common cause of intestinal obstruction is 6 month to 3-year age group. First point to remember: abdominal pain, nausea, vomiting, red currant jelly stools will be there. Ultrasound can show coiled spring sign. Target sign has also been explained in this. Water soluble contrast enema is done, but remember, enema is contraindicated in suspected perforation. They will not say there is perforation. If they make a clinical question, they will add something related to perforation. There will be tenderness, guarding, rigidity, and then ask about interception. The answer will not be enema. You will have to do laparotomy, surgery in these patients if there is perforation. Moving further, question number 5, round number 5, Dr. Satish, here is your question. Which among the following conditions presents in infancy with cycles of cyanosis with a calm resting child and cyanosis disappearing when the child cries? And your time starts now.
Sir, it is bilateral choanal atresia.
Excellent. Any particular name for this condition? This phenomena, clinical phenomena?
No idea, sir.
It is also called as
Cyclical cyanosis.
Arman has answered it correct. It is also called as cyclical cyanosis. In bilateral choanal atresia, the child cannot breathe through both his nostrils because there is a membrane in the back. So children are obligatory nose breathers, right? So they cannot open their mouth to breathe. So they will develop cyanosis. As soon as cyanosis develops, they will start crying due to CNS irritability. The moment they start crying and open their mouth, some degree of air will move inside, some degree of involuntary exchange will happen, and this will lead to resolution of cyanosis. So when they cry, cyanosis improves, SpO2 improves. When they stop crying, SpO2 falls. Typically called as cyclical cyanosis, seen in bilateral choanal atresia. Immediate, do surgery. Before surgery, obviously, you need to put a emergency airway in these children. So infants with bilateral choanal atresia, whatever I just told you, these are the points which are mentioned here, right? So Satish gets +10. Next, we move to Shagun. Dr. Shagun, here is your question. Yes, question number 6 of round 5. A child is found to have low serum iron, high ferritin, and normal total iron binding capacity. What is the likely diagnosis? And your time starts now.
Sir, D, anemia of chronic disease.
What is the clinching point here? Obviously all three, but which is the clinching point?
Yes, the low iron and high ferritin, the combination of both.
Yes. So you have answered it correct. You get +10 on this. And so the answer is D. Have a look at this table. DD of microcytic hypochromic anemia. In case of low serum iron, high binding capacity, and low serum ferritin, iron deficiency, obviously, because the stores are not there. But because stores are not there, so total iron binding capacity will always be elevated so that whatever iron they can find, they can use it. Serum iron low, high serum ferritin will be there in anemia of chronic disease. There will be problem in mobilization of the stores. So there will be high serum ferritin and low serum iron. TIBC is low to normal. Thalassemia, every parameter is normal to sometimes high normal. Serum iron can sometimes be on the elevated side, but it is a high normal value that we find. Sideroblastic anemia, you will have high serum iron, high serum ferritin. TIBC will be normal to low. So excellent answer to this. Now we move to round number 6. It will be a miscellaneous segment, rapid fire. Each correct answer will get you 10 marks. Partially getting corrected, 5 marks. Total time per question will be 30 seconds. Time has reduced now because now you have to, it is going to be a relatively tougher round. So let us begin with Dr. Arman. Here is your first question. First line, antiemetics in children with cancer chemotherapy and motion sickness. Your time starts now. 30 seconds.
Sir, antiemetic children with cancer chemotherapy is Onset.
Yes.
And for motion sickness, diphenhydramine.
Almost there. You can take the class of agents also.
Name of?
Class of agent, diphenhydramine.
Okay, antihistaminics.
Excellent. So you get it right. The answer to this question is antiemetics in children. Cancer chemotherapy induced vomiting, ondansetron, 5-HT3 receptor antagonist. There is a Either antihistamines like dimenhydrinate or anticholinergics like scopolamine have been found to be equally efficacious, considered to be first-line agents. Ondansetron does not help in motion sickness. Please remember that. A lot of doctors, one of my colleagues, he's a top-notch radiologist. He called me one day saying, I'm going to Manali. बच्चे को बहुत वॉमिटिंग हो रहा है साइक्लिक उसके मैंने तो सुबह ऑन्डेंसेट्रॉन दिया था. आई सेड फार्माकोलॉजी भूल गए हो. Ondansetron will not help in motion sickness. So motion sickness, morning sickness, it will not help. Domperidone you give, it will not help. Give antihistamine, anticholinergics, it will help there. So next is question number 2 goes to Dr. Ibrahim. Dr. Ibrahim, here is your question. Name 2 conditions where IVIG is the first line therapy or the therapy of choice in children.
Sir, it is given in Kawasaki disease and Guillain-Barré syndrome.
And
Guillain-Barré syndrome. Guillain-Barré.
Absolutely right. You get plus 10 on this. Any other you can add?
Sir, now it is also given in MISC of the Kawasaki disease phenotype.
Yes. Correct. That will come under the ambit, but yes, that can be taken. So classically speaking, pediatric conditions, IVIG is among the first line therapy. Kawasaki disease, Guillain-Barré syndrome, acute ITP. In addition, MISC, yes, it is one of the first line drugs. In addition, in case the patient is having severe immune-mediated hemolysis and facility for exchange transfusion is not available, there also IVIG is the only drug which is available that you can use as a life-saving measure. So you get plus 10 on this. Next is question number 3, which goes to Dr. Prabhupada. Dr. Prabhupada, here is your question. Let me just say, number 2 conditions where congenital heart disease shows cyanosis and improves with prostaglandin infusion. Your time starts now.
Sir, hypoplastic left heart syndrome.
Hypoplastic left heart syndrome. Okay. And
coarctation.
No, the time is over now. It's a tough question, I know. Anybody wants to volunteer for this question?
Duct-dependent lesions, which
Name.
Sir, severe pulmonary stenosis, TGA, truncus arteriosus.
Yes, severe pulmonary stenosis, or you can say pulmonary atresia, where the valve is totally gone. And other than that?
30. Also, there can be hypoplastic right heart syndrome and tricuspid atresia.
You need to understand what are duct-dependent lesions, where survival is improved by giving prostaglandin. Normally, you want ductus arteriosus to close, but there are certain conditions you want it to remain open. All those conditions where survival is improved, we call it as duct-dependent lesion. Duct-dependent lesion can broadly be classified into 2 groups with subgrouping. 2 groups are those where cyanosis improves with giving prostaglandin, those where shock improves with opening ductus arteriosus. Those where shock improves are called as duct-dependent systemic lesion, which includes hypoplastic left heart syndrome, severe coarctation of aorta, and aortic atresia or severe aortic stenosis. Those where cyanosis improves are Epstein's anomaly, tricuspid atresia, pulmonary atresia, and hypoplastic right heart syndrome. There is another entity called as pure TGA or TGA with intact ventricular septum. There also cyanosis improves, but the mechanism is slightly different, so it has a sub-classification of its own. So the answer to this is these are the cyanotic CHDs which improve with PGV1. TGA with intact ventricular septum, it has a separate subclass. It is also called as duct-dependent oxygenation lesion. Other ones are duct-dependent pulmonary circulatory lesions, Epstein's anomaly, tricuspid atresia, hypoplastic right heart syndrome, and pulmonary atresia. It's a tough topic, tricky topic, but very beneficial, especially for Central Institute PG entrance exam. Anybody wants to tell me any condition? It's an old AIMS MCQ. Name the only cyanotic heart disease which dramatically worsens and kills the child.
Intracardiac.
Which type?
Intracardiac.
Yes. Why?
Because it is obstructive type. So
yes, obstructive type. Yes, absolutely right. So you know the answer. So unfortunately, Dr. Prabhupada doesn't score here. Dr. Ribhav, question number 4 comes to you. Here is the question. Name a condition where congenital infection produces cerebral calcification, and also you have to mention the type. And second is headlights in the fog appearance is seen. Your time starts now. 10 seconds gone already.
Toxoplasmosis.
Okay, for which one or two?
For the second part, headlights in the fog.
Toxoplasmosis कौन सा? मतलब in you and me?
नहीं sir, congenital
You have
toxoplasmosis.
to say na congenital toxoplasmosis. And 5 seconds to go. 3, 2,
I don't know.
1. Okay, you get +5 on this. Anybody wants to volunteer? Yes. CMV causes
And-
periventricular calcification and diffuse cerebral calcification. So remember that periventricular calcification is seen with congenital CMV. Diffuse cerebral is seen in congenital toxoplasmosis. Congenital toxoplasmosis also produces headlight in the fog appearance when you do ocular examination. As you can see, whenever a light is approaching, there will be blurring and a headlight appearance as if a fog may there is a approaching light. That is the typical headlight in the fog appearance seen with chorioretinitis involvement in congenital toxoplasmosis. So Ribov gets +5 here. Dr. Satish, question number 5 comes to you, round number 6. Here is the question. Name a condition where hypersegmented neutrophils are seen and name a condition where the following image is seen. Your time starts.
Hypersegmental neutrophils are seen in megaloblastic anemia.
Correct.
The following are it is seen in iron deficiency. No.
You still have 10. Okay, the time is gone. One part of your answer is correct. See, इस तरह का black and white image if you find, remember, ये वाला जो photo होगा, this will always be a electron microscope, right? It is always black and white. So black and white ऐसा filter लगाते हैं ना, तो ऐसा ही आता है. So electron microscopic picture showing what? Somebody was saying something.
Birbeck granules.
Birbeck granules.
Birbeck granules. There is a tennis racket shape appearance and a zipper handle. So that is the typical Birbeck granules. So hypersegmented neutrophils are seen in megaloblastic anemias. Birbeck granules are seen in Langerhans cell histiocytosis. So LCH is the answer. Please remember LCH markers, one of the favorites of AIIMS entrance exam people. Every alternate 2-3 saal ke baad, they will ask about the details of it. So go through LCH in details for future AIIMS or INI-CET based questions. Now, Dr. Shagun.
Yes, sir.
Question number 6. Name the drug of choice in steroid-resistant nephrotic syndrome and Diamond-Blackfan anemia.
So Diamond-Blackfan anemia is a type of pure red cell aplasia. And steroid-resistant nephrotic syndrome, we use calcineurin inhibitors,
Correct.
tacrolimus, cyclosporin.
Yes, but Diamond-Blackfan anemia, what is the therapy? There must be some.
So
drug.
it is a type of hyperproliferative.
Yes,
Oh,
but it
drug
is
of
a type
choice.
of hyperproliferative disorder which responds
Yes.
to. You still have 10 seconds to go.
So immunosuppression.
Which
Erythropoietin.
there is a whole list. You need to take a drug. 3 seconds to go.
Rituximab.
Wrong. Diamond-Blackfan anemia is a congenital hypoproliferative anemia which dramatically responds to corticosteroids. Prednisolone is the drug of choice which produces a remission in 80% of these patients. Those who are unresponsive or after some time prednisolone stops responding, then obviously stem cell transplantation needs to be done. So question number 6, your
Immunosuppressive therapy.
yes, you said immunosuppressive therapy, but you need to name a drug, and you mentioned then rituximab after that. So I cannot give credit in this.
Okay.
I'm really sorry. So drug of choice in steroid-resistant nephrotic syndrome, calcineurin inhibitors, cyclosporin, tacrolimus, Diamond-Blackfan anemia. The answer is prednisolone. So we are done with these questions, and at the end of this, everybody has performed excellently here. So what I can see here is that there are a lot of people at almost similar level, similar standing. So you have Dr. Shagun at 10, 20, 30, 40, 50, 55 out of 60, right? Dr. Satish is also at 55 out of 60. Then Dr. Ribhav, 10, 20, 30, 40, 45 out of 60. Dr. Prabhupada, 1, 2, 3, 4, 40 out of 60. Dr. Ibrahim on again, similar, 55 out of 60. And Dr. Arman is again at 55 out of 60. So that means there are 4 people at a similar score. So we need to go in for the tiebreaker round here. Now, when I say tiebreaker, this will be between Dr. Arman, Dr. Ibrahim, Dr. Satish, and Dr. Shagun. And whosoever says it first will get the answer. In case you say it incorrect, you get -10. So that will be deducted from your score. So say it only if you know the answer. There is no time limit here. About 1 minute will be given. You need to say, I want to answer. You don't answer it directly, I want to answer. But if you say your name, you have to answer something. If you say your name, say you say Arman, and you don't answer it, that will be minus 10 from your score, right?
Okay, sir. Yes, sir.
Okay. It will be 10 seconds after saying your name. The other people can keep on thinking also. So you get bonus time for that, right? So the question goes now. Everybody ready?
Yes, sir.
Okay. Erythrocyte glutathione reductase activity is used to measure the deficiency.
Shagun.
Ibrahim.
Shagun has said it.
Vitamin B2, riboflavin.
Is riboflavin, and that is a correct answer. So Shagun gets a plus 10 here as well. Who was saying other than that? Dr. Ibrahim?
Yes, sir.
Dr. Ibrahim, your answer was same?
Yes, sir.
So just a matter of saying out, but there was no lag, I think. It was
Yes, sir.
at all levels. So Dr. Shagun has got the highest score here, and just by a thin margin, Dr. Shagun is the winner of this pediatric quiz. So congratulations, Dr. Shagun, and a round of applause from my side. And I think I'm right now interacting with one of the brightest people, because trust me, I interact with a lot of people, both at PG level and even at super specialty level. And MD करने के बाद भी लोगों को नहीं आती हैं चीजें aspects, but they don't know the theoretical things and the practical things, which many of you have got it so well. And I'm really looking at a very bright future for all of you. Right now जो हमारा score है उसके अंदर Dr. Shagun is the winner. Along with Dr. Shagun, the next number is so the first ranker is already decided. Dr. Shagun is our ranker. Other than that, now there will be a tiebreaker between Dr. Arman, Dr. Ibrahim, and Dr. Satish, right? So only these three people will be answering. Yes, current scores, Arman is at 55 out of 60. Ibrahim is at 55 out of 60. Satish is at 55 out of 60. And Dr. Shagun, because the previous phytobezoar question was not audible, so we did not take it into account, even though she answered correctly. So other than that, she is 65 out of 70. So basically, she has answered the tiebreaker among all four people. So she is the ranker. Satish, Ibrahim, Arman are all at 55 out of 60. Okay. Arman, Ibrahim, and Satish, can you hear me? All three, please say yes.
Yes, sir.
Yes, sir.
Yes, sir.
Okay, all can hear me. Okay. So, in a child with acute kidney injury with acute tubular necrosis, the child was advised fluid restriction. Okay, fair enough. When fluid restriction was performed, it was decided that the child will be given only fluids equivalent to urine output. So urine output replace hoga, along with replacement of insensible losses, along with replacement of whatever extra losses are happening, like those from GIT. How will you calculate the insensible losses? What is the formula to calculate insensible losses in a child with acute kidney injury? It's mentioned in Ghai, indirect question in PGI entrance exam. 10 seconds is gone, extending to 30 seconds. Say the name only if you know the answer, otherwise you will get deduction for this. 30 seconds also gone. Anybody else wants to try? Dr. Prabhu, Dr. Shagun, Dr. Ribab? No? 400 ml per meter square body surface area. That is the answer. Okay, so you can add this point, you can read later. Okay, mushkil ho gaya, but mushkil karna hai because I don't want everybody to answer, and it should be relevant to. I will not ask anything which is out of OP Ghai. It will be in the realms of OP Ghai only, right? Okay, next question. Again, tiebreaker between Arman, Ibrahim, and Satish. Here is the next question. Slightly easier. Name two criteria, and you have to tell the value to define nephrotic range proteinuria in a child.
Arman said.
Sir. Satish.
Okay, Arman said the name.
Yes, sir.
So, Arman, what is
Sir, the proteinuria can be if the urine protein to creatinine ratio is more than 2:1, and the proteinuria is more than 40 milligram per meter square per hour of proteinuria.
In urine? Absolutely right.
In urine.
Absolutely right. And Dr. Arman, congratulations. You get the second rank in this tiebreaker. So there are three ways you can define nephrotic rich proteinuria. Two Arman has already said. Third is urine dipstick showing 3+ or 4+ urine protein. It is useful only for follow-up, not for fresh diagnosis. For fresh diagnosis, you either need 24-hour urine protein, which or whatever you can get more than 40 ml per meter square per hour, or spot urine protein by creatinine ratio more than 2:1. And now we have Dr. Satish and Dr. Ibrahim for the third position. Even if you get fourth position, don't worry. You all people have done exceedingly well, and I'll try whatever I can to make sure, like I'm hugely impressed. I'm hugely impressed with all of you. So irrespective of the rules of this, I'll try to make sure that some academic thing is provided to you. So I'll make sure that. Other than that, let me just find another question of your level. This will be only between Satish and Ibrahim. Let me just try to see. Okay, it's a controversial one, but a one-liners nonetheless. There is a 5-year-old child who has history of frequent falling since 2 years of age. Ibrahim and Satish, can you hear me, both of you?
Yes, sir.
Yes, sir.
There is a 5-year-old child who has a history of frequent falling since 2 years of age. At 5 years, he is found to have a positive Gower sign. His hypertrophy is also found to be there in both the limbs, and his serum CPK is found to be in a range of 50,000. I have not yet asked the question.
Okay.
What is the investigation of choice that you will do to confirm the diagnosis of muscular dystrophy?
Sir,
Ibrahim.
Satish.
Both of them have said this again. Sir bola Satish ne, Ibrahim ne bola. Ibrahim?
Sir, muscle biopsy.
Ibrahim is saying muscle biopsy. Okay. Satish, your answer?
Muscle biopsy.
Okay. Both of you get -10. It is genetic analysis.
MLPA.
Yes. Genetic diagnosis is the mainstay of diagnosis in patients of muscular dystrophies. Muscle biopsy is invasive, and it is only reserved in cases where genetic analysis is not available. It is an update, and it is a very frequently asked thing, especially if you get a case of muscular dystrophy as a long case in the final viva. So both of you get -10 on this. So, but again, your score still lies above other people, your compatriots. So again, there will be a rank decider between Ibrahim and Satish. Again, you are making my job even tougher. Now I have to again find another question. Okay, slightly descriptive, but purely OPGI based question. Okay, Ibrahim, Satish, can you hear me, both of you?
Yes, sir.
Yes, sir.
Okay. Kwashiorkor child develops acute gastroenteritis, presents to you with severe dehydration and shock. What is the fluid of choice you will use?
Sir, Satish.
Satish. Okay.
Yes, sir.
Fluid of choice.
Sir, ringer lactate with 5% dextrose.
Excellent. So finally, Satish gets rank number 3 here. Ibrahim, Prabodh, and Ribab, all of you need not worry. You have done exceedingly well. It has been a very close fight, depending upon the level of questions also. Sometimes, yes, our mind just doesn't work. So the overall ranks are Dr. Shagun is the winner of this quiz, followed by Dr. Arman, who stands second, and Dr. Satish stands third. But Ibrahim, Prabodh, and Ribab have also done exceedingly well. So after this round is over, after this session is over, so all of you, all the best. Congratulations, Dr. Shagun, Dr. Arman, Dr. Satish, and even Dr. Ibrahim, Prabodh, and Ribab. You all have done exceedingly well. All the best for your exams.